Good morning. Welcome, and we're excited to present the next block, which is molecular biology and sarcomas. I have the honor to present Dr. Pablo Deitos, who is a professor of pathology, chair in the Department of Integrated Diagnostics in the University Hospital of Padua, also the Dean of the University of Padua School of Medicine, and he's going to start today.
So good morning, and thank you for inviting me here. What I will try to do the next 15 minutes is to clarify how NGS can be a tool in sarcoma diagnosis, but also how sometimes NGS is not necessary at all, which means that you can make the diagnosis without very complicated diagnostic tool. Sorry. So, as you know, sarcomas are pretty heterogeneous, pretty rare. They do represent a challenge diagnostically, but also from the therapeutic standpoint. And one of the things which has been, in a way, promoted through the years, particularly in the medical oncology environment, is why don't you abandon classical morphology and you simply start using molecular genetics? So is there a good reason to replace morphology with molecular diagnostics? I would say no. There is no reason at all. So I think I set up like 3 top-notch molecular genetics lab in my life. Currently, I think I pay the salary to 25 molecular geneticists. So I believe in molecular genetics, just we need to place molecular genetics in the right context. Why I do not believe that we are going to replace? Because molecular genetics is not 100% specific for any entity. And the most dramatic example, as we also mentioned yesterday, is this type of fusion genes that can occur, as you can see, both in clear cell sarcoma, the so-called melanoma soft part, but also in a benign lesion, pretty exotic and rare, called angioma-35 cystocytoma. So if you only pick up the molecular genetics, you're going to make horrible mistakes. You have to know that. Of course, pathological classification is important because at the end of the day, it represents the rationale of clinical decision-making in any field of oncology, but also, in particular, in sarcoma diagnosis. And of course, as a clinician, you expect from us also prognostic, biomarkers, predictive indicators, and so on. And in this context, even if, the technology has evolved dramatically through the years, morphology is still a powerful tool. So we don't need to abandon the microscope, or if you want to go digital, the good screen that we can get nowadays to make morphological diagnosis. So, what about MPS? What is the role of molecular analysis in sarcoma then? Well, sometimes you can use for diagnostical purposes. Sometimes we can get prognostic indication, very little, mostly in gastrointestinal stromal tumor. Well, prediction is growing more and more relevant in GIST, of course, but also in other fields because the number of drugs which has become available is slowly increasing. And of course, molecular genetics play a major role in any type of research, clinical, translational, basic. There you can do whatever you like. So what about MPS or NGS? It's just massive parallel sequencing is a better name for next generation sequencing because we are now using a 3rd generation of NGS, which make it not much next anyway. You can use to validate classification. One example is pseudomyogenic hemangioma. And when you describe a new thing, if there is a genetic aberration, it is nice to make the correlation because in a way it supports, it strengthens the concept that you are really describing something new. MPS and GS has helped us in identifying new diagnostic markers. For example, STAT6 in solitary fibrous tumor just appeared because we found the STAT6 NAB2 fusion genes in solitary fibrous tumors anywhere in the body. New entities, CHIC, BCOR, and FATC2, and so on, are all lesions that has been better identified because of molecular genetics. And then, of course, you can use to elucidate sarcoma pathobiology, or I think I will just make the example of NTRK as a situation in which you use molecular genetics to find new potential targets. But don't forget, what we really do nowadays, even if you do, like the 500 genes, this is not whole genome or whole exome. This is just hypothesis generating technique. What we do most of the time is target seq, which is, of course, in the diagnostic setting, also in some kind of hypothesis testing. If you had to do whole genome sequencing with the same depth of targeted sequencing, you will get your results in a couple of years. Or maybe now with the quantum computing, that will be easier, but still a little bit expensive. So what we do for diagnosis, mostly gene fusion nowadays, particularly in the field of undifferentiated round cell sarcoma. That is the area where I use the most NGS. And this lesion has been defined by the fusion. There are prognostic differences. Of course, you may argue that separating undifferentiated round cell sarcoma, telling apart from Ewing's, is of limited clinical utility, but if you don't keep them separated, you will never know. You will have prognostic differences, and maybe in the future, we will be able to run clinical studies just specific for these different diseases. Remember, I will go back in a minute to that, more and more gene fusion testing can be replaced by immunohistochemistry. I will show some examples. And as far as copy number variation is concerned, which is MDM2 basically, and you know that you get amplified, these proto-oncogenes, well-diff lipo, intimal sarcoma, and a couple of very rare osteosarcomas, low grade most of the time. Well, again, immunohistochemistry in good hands is equally informative, which doesn't mean that you don't need to do FISH if you like, or real time or whatever. You can do whatever you like, but just know that immunohistochemistry is equally effective and cheap and faster. Then gene mutation, of course, the best champion is GIST. GIST is molecular is mandatory for prognosis, for prediction, so you can't diagnose a GIST nowadays without then getting a molecular profile. Desmodified fibromatosis, again, immunohistochemistry is equally informative, but if you want to be top-notch, okay, you can run molecular analysis of beta-catenin gene. And so it is for IDH in chondrosarcoma, but again, immunohistochemistry is still informative. So what about new molecular entities? Well, it depends. We have things like CHIC, like BCOR, which is now well established. Then, the furious run to use RNA-seq generates kind of diagnosis like this. 2 cases, 1 cases, no enough clinical history, no enough follow-up. To be entirely honest with you, I'm not entirely sure this is going to be helpful because I don't see what is the message I can offer to our clinical colleagues. So we recently have, last week we got this new one, CRTC1SS18, novel sarcoma subtype. We have like 3 cases reported in the world. The follow-up is very limited. God knows what we're going to do with this. I'm not saying we shouldn't do, at least in the places where we accrue a huge number of cases. Academically speaking, it's very interesting. I'm not entirely sure this is going to be interesting from the clinical standpoint. Because most gene fusion that we observe nowadays, the more you NGS those, are stochastic events. And this has been clearly demonstrated by some of the god of molecular genetics in sarcoma, like Frederick Mertens and Felix Mittelman. So as you mentioned, some is real, like cheek, like BCO, and some Italian friends, most of all Emanuela Palmerini, who's in the audience, in the end managed to show clearly that BCO behave clearly better than Ewing's and cheek. And this is very valuable information from the clinical standpoint. Whatever the chemo you want to give them, but in a way you know that you're dealing with the more aggressive diseases or a less aggressive diseases depending upon the fusion. And what about potential targets? I mean, we were lucky enough a few years ago. I was always interested in so-called wild-type GIST, those GIST who doesn't get anything genetically. So we found these ETV6 and TRAC3 in one GIST, which in a way generated the interest of the drug company in developing, agnostically, drugs against TRAC. And as you know, now we get 2 drugs approved agnostically, so you can use whenever the molecular genetic for the fusion is present. And this is the other one. And which is interesting because those cases were amazingly enriched by infantile fibrosarcomas, another bunch of cases yet to be defined properly that do have TRAC fusions but have the tendency to be benign most of the times. So the problem here is that this tumor is exceedingly rare. In my place, we centralize like more than 3,000 cases per year from all over Europe now. And it's interesting how we say in the last 3 years, we have seen probably no more than 4 cases of TRAC-fused sarcomas in which we could apply the therapy in order to downsize the tumor mass. So what is interesting, nowadays, every week, medical oncology asks me to run TRAC on any type of sarcomas, and nobody tells the patients that the chance that the lesion is not there, the aberration is not there, is 99.98%. And you can imagine that as they don't know, the patient don't know, when we say, all right, TRAC is not there, they're really ashamed in a way, because they think we're not enough good in finding the genetic fusion, but the fusion is exceedingly rare. So we all need to be aware when we celebrate, the anti-TRAC story. And my final point is related to comprehensive genomic profiling, which means to look to a substantial number of genes, and the question is whether we should do it routinely. This has been done routinely in Dana-Farber for years, and now they abandoned because the yield is so low in sarcomas. It is not that I don't believe that we need to give a chance to any patients, so it is fine. We do it. We do in my lab. We look 500 genes with a TSO from Illumina. But again, not only in sarcomas, of course, in any type of cancers, the yield is not amazing, but I admit, even we find one patient that is good. What about sarcomas? So if you go to the literature, there is a couple of papers, in particular this one for our French friends, saying clearly that at the moment, data suggests that molecular profiling, extensive molecular profiling, should not be used in routine practice, simply because we don't see a practical clinical utility, which doesn't mean that we shouldn't do in research, hoping for something better in the future, but just we should avoid to tell patients, all right, now your therapy failed, but now we're going to look into your genomics or epigenomics or methylomics, whatever, and we're going to find a solution. This may happen extremely, extremely rarely, so we need to be honest with that. And as I mentioned to you, more and more the genetics can be replaced by immunohistochemistry, which is a different way to see biological phenomena. And for example, the SSX antibody is fabulous in recognizing synovial sarcoma. All right, if you see many, a few may be negative, and then, of course, you may use genetics. But the garden variety synovial sarcoma don't need any more genetic testing for proving their fusions. And this is, as we mentioned yesterday, is also true, which is nice today because the color seems to be fine. Perfect. I wish we had yesterday also. So we can now have like a molecular immunohistochemistry for SYT, for synovial sarcoma, then DDA3, myxoid lipo, CAMTA1, and so and so. So very easy, approachable to anybody in the world to get exactly the same result as using molecular genetics. So my conclusion, I still have 30 seconds. Of course, sarcoma is a challenge. Of course, you need to integrate morphology, immunohistochemistry, and molecular genetics. You need to talk with the clinician to be part of the MDT. But remember that morphology is still very valid. And of course, molecular testing is helpful, but only if used wisely in context with morphology. And with that, I wish to thank you for your attention.
The next talk is in charge of Alberto Righi. Alberto Righi is a surgical pathology consultant. He works in the Department of Pathology, is in charge of the biobank in Istituto Riccioli in Bologna, Italy. So he wants to talk about the translocation test as in the diagnosis tool.
So, good morning to everybody. It's a good pleasure for me to be here. Thank you, Andres, and thank you, Mauricio, to invited me. My presentation is very similar to Paolo's presentation, of course, because our approach is very, very similar, and Paolo is my mentor, and I cannot say different things about his point of view, of course. But in any way, in my presentation, I would like to show to this audience what is our experience with the translocation testing in our laboratory in Rizzoli Institute, because the question is very clear. Are translocation testing a mandatory tool in diagnosis of sarcoma? According to the WHO criteria, the answer is no, with just only an exception, with NFACT2 and PAS1 rearranged sarcoma. In another types of sarcoma, the molecular test is only desirable in selected cases, okay? But what is the percentage of these cases? Because during different talk, also yesterday, many speakers say these chick and BCOR are very, very rare tumor. But what is the exact percentage of these cases? And I would like to share with you what is our experience in our institutions that we started since 2002 to evaluate with the molecular test to confirm the diagnosis of Ewing sarcoma, and we can observe that as more than 93%, in total we have almost 1,000 cases, are classic Ewing sarcoma. And we have just only 4 cases, 0.4% of NFACT2 and PAS1 cases, with a prediction of bone location. Of course, in Rizzoli, we have mainly cases of the extremities of bone and soft tissue. And it's interesting to observe that in the soft tissue, we have more than 25% of cases that show a cheek rearranged sarcoma. Instead, BCOR are more frequently in the bone. And this one is our distribution of this more undifferentiated small round cell sarcoma. As Paolo said before, this molecular test can be replaced to immunohistochemical marker, and I would like fastly to show some examples. This is a STAT6 in solitary fibrous tumors that works very well, and we use in the routine practice. It is important to underline that these all antibodies showed a nuclear expression and are very feasible with a good specificity, a good accuracy. This one is another example of MUC4 in low-grade fibromyxoid sarcoma and the epithelioid sclerosing sarcoma that is feasible not only in soft tissue cases but also in bone cases after the calcified process. This one is a CAMTA1 and TF3 that using molecular tests has been clarified this a questionable topic about vascular tumor classification, and using molecular tests and with this antibody we can classify very well this different entity. In fact, in each surgical pathology laboratory should be available these two markers, CAMTA1 and TF3 that are mutually exclusive in epithelioid hemangioendothelioma. And then we have a FOS-B that is expressed also in osteoblastoma, but is also specific for epithelioid hemangioma and is a good marker for pseudomyogenic hemangioendothelioma. And in these cases, it's not necessary to do a molecular test, but is sufficient in the majority of cases to do immunohistochemical test. Another topic is H3F3B in chondroblastoma that is very specific and very sensitive to chondroblastoma. That is, this marker is sufficient to send out a diagnosis of chondroblastoma. Conversely, H3F3A is a good marker, is a sensitive marker for giant cell tumor of bone. But the problem is that H3F3A has been reported in classic and conventional cases without giant cell of conventional osteosarcoma. So keep in touch that H3F3B is specific and sensitive for chondroblastoma. H3F3A is not so specific like H3F3B because it is reported in classic and conventional osteosarcoma without giant cell component. Moreover, we have MyoD1 that is specific for rhabdomyosarcoma, in particular for this new recently described entities that is spindle cell and sclerosing rhabdomyosarcoma, and also, as Paolo showed before, these two antibodies that works very well and have replaced the use of SYT for the diagnosis of synovial sarcoma. It's interesting that also these both antibodies works very well in bone tumor. We have described our series of 25 primary synovial sarcoma of bone, and both these two antibodies works well after the decalcification process in primary synovial sarcoma of bone. And at the end, we have DDIT3 that we are setting up in our laboratory. We continue to use fish analysis, but also this one is a good marker. About undifferentiated small round cell sarcoma of bone and soft tissue, of course, is just molecular test is desirable. It's not necessary to do it because, of course, the molecular tests are not available in all countries in all world. And moreover, in the majority of the cases, the immunohistochemical analysis and morphological analysis is sufficient to send out cases. And before the molecular era, these four different imaging represented a Ewing or a typical Ewing that was called in this way. But after the molecular techniques application, we can distinguish the Ewing sarcoma that we used these three antibodies, CD99, NKX2.2 and PAX7, that three antibodies usually are sufficient to send out to confirm the diagnosis of Ewing sarcoma in round cell neoplasia. Of course, this one is a cheek rearranged sarcoma with myxoid background, with geographical necrosis that showed WT1 expression. But in our experience, we prefer to do in these cases, because we have the availability of the molecular test, we prefer to do RT-PCR and fish analysis to confirm the diagnosis of cheek and of BCOR rearranged sarcoma, even if for BCOR there is a CCMB3 that represents the majority of BCOR rearranged sarcoma, where is available an antibody that works very well. And after the molecular techniques, we can classify this entity with very similar morphology, even if the B-core is more spindle neoplasia more than round cell neoplasia. We can distinguish using these immunohistochemical antibodies, this fourth category, with the prognostic and predictive consequence that Manuela showed in his paper that is recently published. And now I would like to show our result, our experience in Rizzoli, because we are a reference center, and I would like to share with you what is our approach on round cell sarcoma. First of all, we started usually in routine cases with RT-PCR is the first step. 78% of our cases are solved with RT-PCR with EWS Fly1, EWS ERG that represented more than 85–90% of cases of Ewing sarcoma. And the second step in 80 cases is solved by FISH for cheek, for B-core, and for EWS, and just only 4% of cases underwent to NGS analysis before to arrive to a diagnosis. And this one is our experience with this test, with sensitivity and specificity of the different tests. We can observe that the frozen material is the best in terms of sensitivity and specificity, because of course we have a specific test for frozen, and the material is high quality level, and the specificity and sensitivity are very, very high. Conversely, when we use a paraffin embedded tissue, the sensitivity is lower than frozen for the pre-analytic process regarding poor fixation, the over decalcification, or simply because we used the decalcifying solution that broken the acid nucleic links. And instead, the FISH analysis has got not so high sensitivity, because some, for example, B-core, not all B-core rearranged can find with FISH, and also with NGS we have some problem to pre-analytic analysis about the quality of RNA, in particular in bone sample. And this one is a list of all RT-PCR and quantitative real-time PCRs that are available in our lab, and this is a list of probes that are available. In our routine practice, we have done more than 3,070 tests. 51% underwent to RT-PCR, 34% FISH, and 15 not evaluable for fixation, for over decalcification of the specimen. In our experience, we have done just only 107 cases of NGS from internal and external cases, and it's interesting to observe that more than 40% of the majority of cases does not evidence any specific fusion. We use the specific sarcoma panel with 65 specific genes that are the more frequently discovered in the mesenchymal neoplasm. We used in our routine the FISH analysis for MDM2, in particular for low-grade central osteosarcomas, that represent one of the most difficult differential diagnoses with fibrodysplasia in bone pathology, when it's possible to confirm MDM2 nuclear expression. We do it FISH analysis. Another probe that we use in our routine practice is USP6 to confirm the diagnosis of aneurysmal bone cyst, in particular when you have a big and a huge mass with not so clear morphological criteria to confirm, to do the diagnosis of aneurysm bone cyst. And we use GNASH mutation analysis for fibrous dysplasia, in particular in a small biopsy when it's not so easy to find the peculiar features of fibrodysplasia. And at the end, another important entity in which we use the routinary RT-PCR to confirm the diagnosis is mesenchymal chondrosarcoma. And here, to finish my presentation, I would like to replace the slides that I have showed 2 days ago. That is about the central pathological review. This one is relative to our that we have done with Dr. Gambarotti in Risoli of cellnet cases. And we can observe that independently to the discrepancy about the grade and the problem relative to the absence of radiological imaging, that is the main problem that I've observed in our series. We can observe that we have in 6 out 193 we changed in our opinion the diagnosis using a molecular test. In particular, one case of grade 3 chondrosarcoma was a mesenchymal chondrosarcoma confirmed to the molecular test. One case of fibromyxoid sarcoma was an myxoid liposarcoma, and the Cachon cases, the GIST, that is very famous cases, the most important cases of the series that was called a GIST de-differentiated, instead was a monophasic synovial sarcoma, and is interested to observe that one myxoid liposarcoma was negative for molecular test for FISH analysis because it was an hibernoma. So in general, using these tests that are not available in some center in South America, I have changed the diagnosis in more or less 3% of cases. So my conclusions are very similar to Paulo's conclusion, and I would like to stress to do the molecular test when it is necessary, because with morphology and immunohistochemical analysis, we can do a diagnosis, a very good diagnosis, to give a possibility to the clinician to treat well the patient. So thank you for your attention, and I'm here for the question.
Thank you, Alberto. The next talk is the role of NGS to identify drivers. The speaker is Dr. Celso Melo. He is a clinical oncologist of ACE Camargo Center in Sao Paulo, Brazil. He is a leader of El Grupo Brasileiro de Sarcomas.
Thank you very much, Andres, Matias, Tomas, for the invitation. My talk is a little bit hard after the talk of Alberto and Paulo Deitos, but I'll try to defend the NGS for sarcomas. Well, the scenario of NGS to search for driver mutations for sarcoma is really difficult, as you can see here, in comparison to lung cancer, where you have at least one disease and so many targets and approved drugs for these targets. In sarcoma, the scenario is a little bit different. You have many disease called sarcoma and a few targets identified so far. Most of these targets are based on GIST and other specific disease targets. The definition of actionable target is very difficult, but it has been, we find some consensus on the definition of a target, especially this one defined by the OncoKB, where you have level 1, level 2, where you have approved drugs and drugs that are consensus in clinical practice, and level 3 and 4 that you have only minimal clinical evidence of these drugs for specific targets. So it's very important to stick on these definitions when you search for specific targets based on the NGS test you can do in the routine practice. The largest series that evaluated the role of NGS in search for molecular targets in sarcomas was conducted by the group of Memorial Sloan Kettering Cancer Center with more than 7,000 patients they evaluated by Oncotype Foundation. And they found that at least 1/3 of the patients have actionable mutations, and these mutations, usually they are level 3 based on the OncoKB. And as the first sight you see this data, you are kind of motivated to do NGS for our patients. But when you look deep in this data, you can see that most of the patients that has level 1, level 2, and even level 3A driver classification, these patients, maybe they wouldn't need NGS, or they would need at least one single gene analysis or limited customized panels, for example. These patients, for example, they are GIST, that we don't need NGS or mass parallel sequence as mentioned by Dr. Deitos. Just a simple gene sequence or genotyping is okay. The other one is epithelioid sarcoma, that you don't need NGS to classify this patient, and just need to search for this MARCB1 mutation, for example. The other one is chondrosarcomas, that you need to search for IDH1, and the last one is PCOMA with mTOR disruption, for example. Most of the targets that you have for these mutations, they can be searched by simple gene analysis. And we question what's the really rule of NGS to search for molecular drivers in sarcomas. Another use of NGS for sarcomas and other tumors is to search for TMB, and also MSI, microsatellite instability, to search for as a predictive biomarker for immunotherapy. And as you know, most of the sarcomas, they have a low TMB, and in this analysis, with more than 7,000 patients analyzed, only 3% of the patients had TMB above 10 mutations per megabase. That's approved for agnostic indication of pembrolizumab for these higher than 10 TMB in agnostic disease indication, actually. And this study found a low mismatch repair deficiency profile. Only 2% of the patients had mismatch repair deficiency. And there was no good correlation on the mismatch repair deficiency and also the TMB, as it occurs in other disease, for example. So at least for sarcomas, the use of NGS to search for TMB and MSI is not a good approach. What's the rule of NGS in accordance with the type of sarcoma, the molecular background of sarcomas? You know that 1/3 of the patients with sarcoma, they have a translocation specific mechanism, and these translocated sarcomas, they have few mutations, few target mutations. On the other hand, most of the patients with complex genomic sarcomas and those with other type of translocations, they have concentrated the most of the targetable drivers mutations, as shown by these NGS studies. So when you perform NGS for sarcomas, you should avoid using NGS for translocated sarcomas at least. Going now to the clinical evidence of benefit from the treating patients with these alterations. When you find some alterations and you treat these patients with some specific drugs against these alterations, there are few data evaluating this approach. One is from the Memorial Sloan Kettering series, where they found that over 118 patients that was sequenced by Foundation Medicine, 1/3 of these patients were included in clinical trials based on the molecular profile of these patients, and only a few patients were benefit from these strategies. And just to show two examples of patients that were treating with this approach, these patients were found to have higher TMB, and this patient respond very well to immunotherapy. One is UPS, and the other one is refractory PCOMA with a higher TMB that maybe is the good predictor for response to nivolumab and pembrolizumab also. Most of the cases of response to NGS drivers is anecdotal, is only a few reported cases. The other series that has explored this strategy was one from US that showed that more than 100 patients that was sequenced, only 3 patients benefited from these strategies. And you can see here that most of these patients were treated with CDK4 inhibitor, for example, palbociclib. And this patient derived some benefit from these strategies. The other one didn't show any benefit. And the question is that you should do in this scenario is there CDK4, for example, one of the most frequent mutations found in the NGS, a good predictive biomarker? And one study just recently published by the Spanish group evaluated the expression of, it's not the NGS, but it's the expression of CDK4 and 6 in sarcomas other than differentiated liposarcoma. And they found that CDK4 inhibition with palbociclib could have some benefit, could have some activity in other sarcomas than the differentiated liposarcoma, for example. So the best way to evaluate a biomarker is to conduct prospective single-arm or randomized trials to evaluate the clinical benefit of these strategies as conducted by the Spanish group. Going back to the data, the NGS with the large series from the memorial, you can find that most of these series are identified level 3A and level 3B with some clinical evidence of benefit for patients without any approved drugs. And the only alternative for these patients is to be included in a clinical trial. Of course, you know that most of the clinical trials for sarcomas are in US and in Europe. And of course, if this patient has the chance to be included in a clinical trial, NGS could be a good option. As you can see here in a recent published paper by our colleague from Brazil, Roberto Pestana, they searched for the outcome of patients that were included in early clinical phase trials at MD Anderson. And they analyzed more than 500 patients that were included in these early phase trials. And they searched for the outcome of patients that were treated by the NGS matched approach and those that were treated without these matched drivers. A bunch of subtypes were included in this analysis. And what they show that some of patients treated with this matched analysis had prolonged treatment duration, and of course prolonged PFS also. Most importantly, they showed that the overall survival and the PFS survival of patients treated with the NGS matched strategy was higher as compared to those patients treated with non-NGS matched trials. Maybe NGS, for those patients that have access to clinical trials, is a good prognostic also. Of course, the best way to search for, to validate these biomarkers is to conduct a prospective randomized trial, as has been conducted by the French colleagues, with the multi-sarc study that has been randomizing patients to a NGS-based approach and other or conventional treatment arm. In summary, you can see here in this picture that around 1,000 patients that you perform NGS, almost 40% of these patients, they have identified target mutations. And out of these patients, only 120 patients have received receive a matched drug in clinical trial or outside clinical trial. And out of these patients, only 8 to 30% respond or have a clinical benefit of this strategy. So it's very difficult to conclude that NGS is a good strategy in search for clinical trials. How could you optimize the use of NGS? Of course, you should sit together and to create some guidelines and create some recommendations algorithm. For example, this one that has been conducted by an international joint for the NTRK use. That's very interesting because they categorize the level of indication of NTRK fusion search for sarcomas, for example. It's a good way to rationalize our resources and to save some money. In conclusion, you can say that is there any rule for NGS to identify treatment for sarcomas? NGS is not useful for the majority of patients with common sarcomas. If clinical trial is not an option, for example, here in South America. It may be helpful in rare seed types and complex genomics avoid in translocated sarcomas. Of course, GIST is another talk. Maybe limited panels should be adequate, and you should avoid MPS for these patients. Treatment decision should be based and validated by a MDTB before indicating any drug for these patients. Of course, the clinical benefit is unlike in this, with this approach. And of course, we need cost-effective studies to validate this practice. And I just asked ChatGPT what he thinks about NGS for sarcomas. And of course, the conclusion is the same. NGS may not be universally applicable to all the sarcoma patients. It's a valuable test in the oncologist toolkit. Of course, it's very broad recommendation. And with this, I would like to thank all the participants. I would like to give a big thank to Javier for the opportunity to give us to participate in this journey, in this 4-year journey. And thank you very much.
For the last part, I would like to invite our panelists to sit, and we will have a case discussion. And in that case, I have the pleasure to introduce Dr. Maria González Dona. She's a medical oncologist, clinical medical oncologist in charge of clinical investigation at the Instituto Nacional del Cáncer of Paraguay, coordinator of the Cellnet Group at the INCAN, and director of the CTOBS Clinical Research in Paraguay. Doctor.
Well, hi. Thank you for the invitation. Thank you for all the Cellnet Group. It's a pleasure to me to be here. I presented a case of a 64-year-old female. She went to the doctor in May 2021 at Kawasu, a city 200 kilometers from Asunción. She went because of abdominal pain and constipation. And do you have problem with the? Okay. No, yes, it's okay. Well, so the patient went to the doctor because of abdominal pain and constipation, and the doctor did a biopsy, and in the biopsy, okay, thank you. Thank you. And a biopsy and CT scan. In the CT scan, we saw a bulky pelvic mass of 14 centimeters in the lower pelvis that displays distal colon, rectum, and the urinary bladder. And in the biopsy, in the hematoxylin eosin stain, we saw a stain, a spindle cell tumor with a large inflammatory background. I have my partners in pathology here that you can ask them, Doctora Cabañas and Doctora Laura Rojas. And so in the higher power view, we saw occasional large atypical cells with vesicular nuclei, with prominent eosinophilic nuclei, nucleoli, with a background of abundant inflammatory infiltrate, lymphoplasmatic, neutrophilic, and eosinophilic, in a foci of myxoid matrix with a mitotic index of 2/10 high power field. In the immunostain analysis, the doctors find a positive Caldesmon and smooth muscle actin. Here is the picture. And the ALK was negative in the immunostain, and the Ki-67 was low, 5–10%. So based on this finding, the tumor was diagnosed as an inflammatory myofibroblastic tumor. And in August 2021, she underwent surgical removal of the tumor, and the biopsy diagnosed a ER1 surgical margin. She underwent a pelvic exenteration. So my question in this part is, do you recommend an adjuvant treatment for this tumor?
Celso.
Yes.
Hola. Celso, ¿quiere decir?
Well, the question is very simple because we don't have any data about adjuvant treatment for non-extremity sarcomas. So usually you don't offer adjuvant chemo for retroperitoneal sarcoma. Most frequently are lipo and leiomyosarcoma. And for this specific subtype, you don't have clear evidence that chemo would benefit these patients. Maybe only follow-up would be okay.
It's okay? Well, I continue. And the other question is which is the role of genetic testing in that kind of tumor?
This case was ALK ROS1 negative, isn't it? Was ALK ROS1 negative?
We didn't do the ROS1, only ALK.
And you didn't NTRK as well?
NTRK, no. We don't have.
Because, you know, to make a call of IMT ALK negative, which is fine for the age of the patient, then you should go for other type of genetic screening. Because if you want to keep on that, I mean, a substantial number of cases may have either ROS1 or maybe you pick up the NTRK3. Was MDM2 performed? MDM2? Oh, you don't have?
No. We do that we have.
No, good, of course. We need to be in the real life, because one of the things that you can have the diff lipo showing IMT-like features, but if you don't have MDM2, of course, it's different.
Yes, well, I'm just going to jump in
Yes,
because
yes.
it was our case. But we don't have MDM2 because the agency that regulates all medication and reactives like these, it's not permitted yet in Paraguay. We're trying to get them in, but we don't have, officially we don't have MDM2 as an immunostain. So that's why we couldn't perform that. And with what we had, And because of the histological appearance, it was very inflammatory, and the cells, most were spindle cells, but most were also epithelioid cells. And it looked like an inflammatory myofibroblastic tumor. That's what it honestly looked like at the moment we saw it.
Yes. Well, the next slide, please. Well, we decided to determine whether genetic profiling could improve our knowledge of molecular partners in that tumor, and the indicator of therapeutic aging. We use next generation sequencing platform. We ask for the patient a Foundation 1. We have a donation of Foundation 1. And so we can find in the analysis an amplification of CDK4 and MDM2, stable microsatellite status, and the tumor mutational burden was 2 mutations for megabase. And the pathology comment Douglas Mata in the inform said that maybe we can think in other diagnoses like Mullerian adenosarcoma, liposarcoma, dedifferentiated liposarcoma. So we sent the paraffin the sample tissue to a central revision by CellNet Consortium, and Dr. Detois, here with us, said, like our pathologists, Dr. Cabañas and Dr. Roja, that it was a myofibroblastic tumor. So this study we received in November, December maybe of 2021, and the patient died near that inform with a large mass, recurrent large mass in the pelvis. So the other question is does the genetic alteration correlate with the clinical aggressive behavior of that tumor, that case? And if we can ask or correlate all that kind of tumors between pathology and genetic analysis, which is your opinion about that?
Well, you know, here the problem was not availability of MDM2, basically, because of course this is not IMT, this is IMT-like, the differentiated liposarcoma. Now we know what it is. And the point with NGS, you know, NGS is not the best way to prove MDM2 amplification in a way. I mean, immunohistochemistry, FISH, real-time PCR is definitely cheaper, faster, and more informative. And by the way, on NGS, now we are publishing data based on RNA-seq, in which now we understand that some of the calls are not real, and sometimes there are calls that are not seen by the system if you don't play a little bit with the bioinformaticians. So again, this case is perfect to demonstrate, in my opinion, than a conventional workout. Of course, if you have the stains available. If you don't have, you can't do anything. And it's probably more supportive to a final diagnosis than going through a very expensive thing like Foundation 1. That, by the way, Foundation has big problems in identifying gene fusion, so they lose 30% of the fusion. So, but anyway, this was a case particularly challenging.
Yes, this was presented in one of the MDTs. Maybe you remember this case because we had that result where the suggestion is that it was probably a dedifferentiated liposarcoma, but it didn't look like a dedifferentiated liposarcoma. And so the discussion was if they had to treat it like a dediff liposarcoma or what. So it was very difficult. The patient,
you're right. I
unfortunately,
mean, in
died.
the end, in this context, I mean, the treatment for the deep lipo is multivisceral resection if we can do. I mean, there is no consensus on which, neoadjuvant chemo would in a way help. Of course, now we know we have MDM2 inhibitors clinical trials going on. I'm pretty sure you don't have in Paraguay at the moment. I mean, so I don't know whether you might have enrolled the patients. But this patient died anyway in 2 months. I mean,
Yes,
so
she
which means
died.
that clinical presentation was really advanced. And
It was
difficult.
very aggressive, and
Yeah.
the tumor, well, we talked with the surgeon, it was below the peritoneum, but it occupied the whole pelvis. Like Dr. Gonzalez said, it displaced all the organs that were in the pelvis, but it was beneath the peritoneum, so it wasn't intra-abdominal, properly intra-abdominal. And they did the best resection they could. It was a huge surgery. And the thing is that the tumor recurred. And after that recurrence, that's when she couldn't recover from that part, unfortunately.
Anyway, you did a good job anyway. So.
Thank you. Thank you.
Well, thank you to the three. And I want to thank you, all the Salnegro, for the opportunity. Thank you.